We are trying to get in touch with Professor Maximilian. He would be the first speaker of the day.
Sorry, I'm on my way. Can you hear me?
Yeah.
Oh, yes. Nice to hear your voice. We are unable to see you.
I just need to get, somehow I have no camera here right now, but I get it. Wait a second. So that's me.
Yeah.
Okay, hi again.
Fine. So, Professor Sinha, if you
Yes.
You
So,
can see me?
yes, I can hear and I can see both. Hello. How are you? Fine. So, क्या हुआ? So, good afternoon to everyone. So, on behalf of WFNS Neuro Rehabilitation and Reconstructive Neurosurgery Committee, I welcome all the speakers and attendees on this webinar. And we have 4 speakers today, and Dr. Maximilian from Germany, Dr. Ruth Marshall from Australia, Dr. Achal Sharma, is from my city, Jaipur, India, and Mehdorn, Dr. Mrs. Cheng from Malaysia. Everybody will be given 20 minutes for presentation and 5 minutes for discussion. And we have 2 panelists, myself and Dr. Visochi. Dr. Visochi may not be joining today because he was called by his dean by university. So, and this webinar will be moderated by Dr. Amit Chakravarti, who is senior neurosurgeon in my city, Jaipur, India. So can I request Dr. Amit Chakravarti to start the webinar? Dr. Amit Chakravarti.
Thank you, Professor Sinha, for the introductory note. So the first esteemed speaker of today's webinar is Professor Maximilian Mehdorn. He needs no introduction. He is known to all of us. He's a big name in neurosurgical community. He is the ex-chairman of WFNS Neurorehabilitation and Reconstructive Neurosurgery. He was the ex-chairman, and he is Professor Emeritus and Chairman retired in Department of Neurosurgery, University Clinics, Schleswig-Holstein, Germany. He would be talking about the need of neurorehabilitation. Professor.
Okay, I will see what I can do. I need to get my, I don't know why it doesn't work, sorry. I try to get you to my screen. I say open screen for all. Do you have to open the screen for me, or should I do it?
No, you can open screen by yourself. Maybe you can if you can press the green icon, share screen.
Yeah,
and
that's what I do.
the PowerPoint. So the PowerPoint presentation page should open up, and you can just click on
it.
it.
Open, but I have it here, and I opened it once. And wait a second. Can you see it now?
No.
I don't know why you cannot see it. I open, and if I say now, open now,
Mhm.
I don't know. If I say again, now I'm with you again, but PowerPoint doesn't open up with me. Dropbox, no, it's stupid. That's all stupid. I'm in a totally different, wrong line right now. So sorry. Now I've lost you again.
No, we are able to see you.
You can see me. Can you see my screen now?
No.
Oh, sorry. Now
Are you clicking on the share screen option?
I
And
did it.
What all can you
I've
see?
done already. So now I try to go back to the meeting. I don't know what it's. Now I'm with you again, and I try to do this one again, and it says me everything like Dropbox online and all these things which I don't want to. Now I go back to my big screen. And can you see my screen at least? No, no?
No, we cannot see your screen. We can just see you and we can hear you.
Yeah, so I'm struggling to survive somehow. And either I can see my PowerPoint presentation or I can see you. So if I do like this,
Okay.
it goes.
When you click on the share screen option, does a small screen pop up? Small page, does it pop up?
I have this one.
Mhm.
Yeah, I have this one just in the middle. I have security participants chat and so on. I've opened keep the screen, but then I have this bigger, I have seen desktop one where I see you, and then I whiteboard, iPhone via, and so on and so on. So it's wrong. I don't know what's happened now because I've done this several times, but I don't know what I do if I do like this again. I am in the wrong file or whatever. So maybe I try. Wait a second. I don't know what kind of ugly thing I'm doing, because when I.
So Professor Maximilian, with
Yeah.
your permission, should we start with the next speaker? And
Sure.
in the meantime, we can try
Of course,
to solve your issues.
Perfect. Yeah. Okay. No problem.
Okay. Thank you. So technical hitches here and there, that's a part of online webinars. So we go on to the next speaker of our day, Professor Ruth Marshall. She is Associate Professor and is the current President of International Spinal Cord Society, having taken over on 5th of September this year for a 2-year term, and is the first woman elected to the position. Congratulations, ma'am. She has been the medical director of the South Australian Spinal Cord Injury Service, SASIS, since 1986. Dr. Marshall is considered an expert in spinal cord injury management, especially the medical sequelae, long and short term, and rehabilitation issues throughout life stages. Her interests include issues to do with the living with the spinal cord injury and the effect of aging, bone health after spinal cord injury, improving outcomes during acute and rehabilitation stages, and preventing late complication using telehealth systems. Today, she would be speaking about neurological rehabilitation in the time of COVID-19. Over to you, ma'am.
Thank you. Now I've got to try and share my screen, which is, we did it before, and now I can't find it. It must be the day for us having some technical problems. If I open up the Zoom, yeah, I can't.
So below you can see a slide.
We had it before.
Yeah, you. Can you
Yeah.
see the slide share option?
No, that's what I can't see.
If you can bring the carcass.
Yeah, no, got it. Okay. Now, let me go from the start.
You
And
can see it. Now we can see it.
Yes.
you can see it. Great.
Yes. Bingo.
So I'm going to talk about really the team approach in neuro rehab in the time of COVID. And I hope that what I'm saying makes sense to all of you. So that's my feeling about COVID. Now I have a disclaimer. I live in South Australia. We've had less than 600 total cases of COVID. We've had only 4 deaths. All but 4 have recovered. The number in hospital is 0. We may have the deaths wrong for the Australian numbers, but our total cases are about 28,000 and our deaths have not reached 1,000. So we're in a very privileged position, but we've been very careful. The number of my patients who've had COVID, none. So I actually have no experience with COVID in SCI rehab. My colleagues in Adelaide have had some experience with COVID in general neuro rehab, mainly associated with deconditioning. But as we all know, the problems don't go away once people leave hospital. So because I have no personal, I've also received lots of information from our colleagues in Italy and the US. So here's a lesson in philosophy. There are lots of different teams, multidisciplinary, interdisciplinary, and transdisciplinary. And to some extent, all our teams work in these ways, often in a mix within the one team. So the multi-D team involves a range of health professionals utilizing skills and experience of those individuals from their different disciplines, and each discipline approaches the patient from their own perspective and develops comprehensive patient care. We need to have, it comprises core discipline work, and together, but individually, they work together to create good care. Interdisciplinary is a bit different, and this is where you have a group of healthcare providers from different fields working closely together, integrating their separate discipline approaches to build on each other's expertise to achieve common shared goals within the team and including the patient. We know that in neuro rehab, this provides better outcomes for our patients, and it's a collaborative process. Transdisciplinary teamwork takes it one step further, and there's interprofessional collaboration at a deeper level and a degree of role blur that can occur so that you have people doing using their expertise, but maybe in some situations utilizing somebody else's, and they provide the hands-on. It's seamless and fluid, and people work very closely together, sharing the same treatment plan and or goals, regardless of discipline. And there has to be a degree of trust and mutual respect. It's an extension of the interdisciplinary team to something that's even better, and I think is seen best in community-based rehabilitation and home care rehab. The transdisciplinary team requires each member to become sufficiently familiar with the concepts and approaches that their colleagues have as to blur the disciplinary bounds so that they can engage in teaching and learning from each other. Disciplinary lines are blurred and the team members share role functions to a high degree with an emphasis on shared responsibilities. In the time of COVID, we have people working together very closely as a team, needing to limit contact with patients with COVID and preventing cross-infection. As a result, you may have one clinician doing the work of another simply because you cannot have too many people in the isolation room. In all the COVID wards and all the COVID hospitals around the world, we have to limit staff numbers and limit visitors, and in fact, in many places, not allowing any visitors. In acute spinal units with a COVID patient, or a neurosurgery unit with a COVID patient, or a stroke unit with a COVID patient, it is important to isolate the infected from the non-infected and to treat the underlying health issues first and treat at the bedside as much as possible. And of course, the caregivers, the staff, all need to wear personal protective equipment. In the rehab wards, we also have to limit the staff and utilize shared goals and trust our colleagues. Again, wearing PPE and reducing numbers in therapy areas and patient rooms and isolating patients and treating them by their bedside. Even in my unit and in my hospital where we have neuro rehab, orthopedic rehab, spinal cord and brain injury all in different units, we had to stop doing our group sessions. We stopped a lot of the things that we have taken for granted and reduced the number of patients in the unit and attending open therapy areas. When it comes to community-based rehab, the important thing, I think, is that you have to treat anyone in the community who doesn't need to be in hospital with shared goals, understanding, protection and prevention. And if you're dealing with infectious diseases, not just COVID, but other diseases or infections, multi-resistant organisms, then staff need to use protective equipment and change it appropriately, maintaining all the good infection control systems that are in place. And if anything, we should be treating more people in the community, not less. So how is this different? With the exception of strict personal protective equipment, it actually isn't different. It's what we do in rehab anyway, on a daily basis. So if you trust your team members and you and your team work with your patient and their family to create and achieve their goals and the team's goals, that's not different. If you're working together with them to achieve the best possible outcomes, it isn't any different. We're still working in exactly the same way. Now, I have an apology. When you listen to this talk, I will not be seeing patients. This is when I gave a similar talk recently. I have an apology instead, is that I'm on holidays and I'm not sure how long I will be able to stay around for the rest of the webinar, but I will try. So I'll answer questions at when needed, but you can also email me, ruth.marshall@sa.gov.au. So thank you for your attention.
Thank you, Professor Ruth, for the nice, crisp presentation.
Can I just say something, by the way? I forgot. And
Yes.
that's to wish all the Indians who are on the webinar a happy National Day for tomorrow.
Thank you. Thank you. Thank you. We have one question for you if you have time.
Yes, certainly.
We are encroaching your holiday time. So one thing which was going in my mind is neuro rehab involves a lot of physical handling of the patient, and obviously the caregivers are wearing PPE suits. But do you change your PPE suit between two patients? Suppose
Absolutely.
Okay.
Absolutely.
Fine. And
although in the beginning, there weren't enough masks to go around. If we think about in Australia 10 months ago, so people were wearing the same mask throughout the nursing shift in particular, which was quite worrying. And as soon as we got enough masks in, it was changing masks all the time. It was, but I mean, we're used to wearing PPEs when we're treating people who have other bugs, not necessarily COVID, but VRE, et cetera, et cetera, et cetera. So in a way, I think we're even more careful with COVID, but with any respiratory bug, where we tend to be very careful, and I just try to stay out of the patient's rooms as much as possible because I'm an old lady and therefore considered at risk. But my nurses wear goggles, face masks, shields, the whole lot. And the goggles, I think, are patient specific. So each patient's room will have goggles. They don't get discarded, but gowns, gloves, masks get discarded when people leave the rooms.
Okay.
Okay. Ruth Marsh, can I ask?
Certainly.
Because rehabilitation is a key to a healthy recovery.
It is.
And we know that this COVID problem had disturbed a lot, and I think almost 63% of countries of the world has suffered rehabilitation protocols. And now I think the condition is decline. COVID is on decline side. So do you have a change any protocol for future or not?
Well, as I said at the beginning,
yeah,
I haven't seen any COVID. There has been one case in our rehabilitation hospital, which is a patient who, in fact, did most of his rehabilitation while in the COVID isolation ward and was virus-free when he arranged, when he came out for rehab, because we could not have any virus on our site. We had to keep it as a bug-free site. But the whole of the health system in Australia has developed protocols which are being used across the board and are really extensions of the protocols we had in place already in terms of infection control, but obviously much stricter. And even now, when I went shopping today and went to several different food shops, and every place I went, I had to log in with my iPhone with a QR code. We don't have to wear masks in public, but a lot of people do. And if I go to a crowded place, I wear a mask. At the moment in South Australia, we don't need to wear masks in hospital in general areas, but obviously we need to wear them in patient rooms if there's any concern about any infection. So in some ways, the infection control systems we had in place are just as effective now, except that we're even stricter. And I think there's a much higher understanding by the general public with wipes to clean your hands when you go into the supermarket, things like that. And children, little children, automatically cleaning their hands. So I think we've rolled out a lot of infection control things that, and we started looking at them, I think, when we got hit with swine flu several years ago. But yeah, I think they've really put in place very fine protocols that we all have in our computers and up on notice boards everywhere.
Can I ask you something as well?
Sure.
I enjoyed your talk, and I envy you living in Adelaide. Our daughter spent 1 year in Flanders and we visited her, so we really enjoyed being down there. You made the remark you always gave your QR code when you enter a fruit shop. So
Yeah.
the police
supermarket, a theater, restaurant.
No,
everywhere.
in Germany, this would be impossible because they always say, well, personality should be restricted, should be taken care of. So we rather wear masks and we rather restrict our society, our economy, but personality should still always be regarded. I think it's awful. We should make more restrictions to and be better able to follow people where they move around like you do in Australia. So how is the personal public feeling? I mean,
it's a bit different in each place, but and different states and territories have different rules. So a couple of weeks ago, I was in Darwin to do a clinic, and they'd forgotten to tell me I had to have had a clear COVID swab within 72 hours, which I hadn't had done. So I then had to, my first day was spent in isolation waiting for COVID results to come back, which was negative, and converting all my patients that day into telephone reviews. But not everybody has it on their phone. Not everybody's willing to do that. They can be pulled up and asked to put in their address or phone number, name and phone number. We're going to a wedding on the weekend coming, and I had a message from the bride. They need our home address because the venue, the rules that have just been rolled out, and they keep on adding to the rules insist that the whole party, the venue has all the addresses of all the people attending. So it's different for different people. I think in health, we're probably more accepting, but, you know, I guess we're very good in terms of the fact that we have accepted that we had to do this. But there were a lot of complaints early on, but it's much more accepted now.
Mm-hmm.
And people realize it because there was a problem in Melbourne and they were in lockdown for 6 months. We've been in lockdown twice, a semi-lockdown, which was for about 4 weeks early on, and in November, a 3-day lockdown. That's it.
Correct.
There is, because we've got no comfort here.
Yep. Excellent.
Thank you.
Thank you.
Okay.
Thank you, Professor Ruth. So shall we get back to you, Professor Maximilian?
Another try. I'll try again.
Yeah.
I don't know why it shows me only your. I see you, I see all of you, but now
Yeah.
it works.
Yes, it's working.
Now it
Yeah.
seems to work, and now I just need to have my PowerPoint coming. Coming?
Yes.
Perfect. Okay, so then sorry
Mm.
sorry to keep you waiting. Okay. I've been asked to talk about general rules for neurorehabilitation, and as you all know, that's a picture taken, I think, in India or in Pakistan, somewhere on the road. Prevention is much better than therapy. Everyone agrees, and we all know that neurorehabilitation is mandatory. And so the optimal path of a neurosurgical trauma patient, from acute trauma care about many steps, surgery, treatment in the ICU, treatment in the rehabilitation unit, with a goal to have him back to reintegration, social reintegration. And we have to try to do this. So neurorehabilitation, the patient's path going home, neurosurgery, neurorehabilitation, it's very important always to remind oneself that we have a combined therapy following various injury. We have to consider a little bit about ethics of neurorehabilitation. Concerns in patients suffering from traumatic brain injury, motor function will become okay, but we never have to forget neuropsychology is also very important. It's also very important in spinal cord injury, and I think Professor Marshall certainly agrees with me. And we have many other things, vestibular rehabilitation, and I mentioned here comprehensive physical rehabilitation of people with spinal cord injuries is very important. Not just only the get them back on the moving, but also to deal with all the problems they encounter, from psychosocial, social problems, sexual problems, and all the other things. Very important to remind oneself. Major goals of neuro are to enable the patients to perform again and show activities toward attractive aims, not just in the wheelchair somewhere and but to do much better. We have to give support to all patients with disease to arrange with a new situation, which is the psychosocial problem to kind fast, but also forward. Very important message. Why is meditation so important? Like if you look at one study from the United States, follow-up 2 years after discharge, when the patients had been evaluated prior to rehabilitation, 70% were unable to work. After treatment, only 6% were unable to work, follow-up of 2 years. Length of stay, 150 days, which is 5 months, which is quite a long time. Fortunately, not all of them are staying so long in this area. We have increasing older people, increasing rate of older people with profound disabilities over the next 30 years. And globally, only 3% of all individuals who would need rehabilitation really get it. So we also have to teach the families to improve on rehabilitation at home. That's very important, and outreach in the low and middle income countries, certainly very important. Lack of routinely collected data, and I'm very happy that Professor Sinha is collecting these data from his area, limited information about the needs of persons with deficits, and different understanding of disabilities of patients, doctors, or of politicians and healthcare management. I remember very well sometime when I was invited by the Neurotrauma Society of India. We also had a discussion with one of the politicians, and they said, well, doctors, you should be more active, taking care of all these patients. But he really was very mooted when one of the senior Indian neurosurgeons told him, well, ask the people and really do this, let the people obey all the traffic rules. We would get out of business if you politicians would work harder on this issue. Very important to understand the difference between medicine and medical and politicians. Policy and planning, infrastructure, and so on. That's very important as well. And rehabilitation is the design of learning a situation to train the brain, the spinal cord, and the nerves to become as functional as possible. That's very important. We have to give incentives to the brain, give incentives to the patient to develop to a really as good as normal area as possible. Training for walking on various grounds early last century, they learned how to do in these areas. They learned quite well. There are other ways to improve on the leg strength and the dexterity by putting all these pipes down or these knobs. And then similar for the upper extremities, similar things. So 2005, 15 years ago, the World Health Organization developed the International Classification of Functioning Disability and Health, which is called ICF. Health problems, body function, environmental factors, personal factors, participations, all is centers around the activities. So we have to take everything into account to get the patient, our patient, as much as rapidly, but as much as possibly back to his normal setting, to his normal activities. We focus on all-day activities and useful actions. And what is important, which we heard also in Dr. Marshall's talk, entire team participates in the narrative reconstruction of the self, and concerning emotion on cognition, they need to be considered as an entity. So the team has to work together, not only just one physiotherapist or one speech therapist or someone else, but they all have to intermingle, and also the caretaker themselves, they should be very much involved in the doctors, obviously. What is important when you look at these rehabilitation units, there are few doctors, but most are different other disciplines who work together, guided by the doctor, but also the doctors learn quite a lot from the other disciplines. So with the ICF, we have to develop a strategy which orients on activities, participation, and the resources of the patient, and not furthermore on the deficits and the disabilities. So it's not how sick is a patient, but how well could we help to get him back as much as possible. So we have a smart strategy. Our aims should be specific, measurable, achievable, relevant, and they should be well timed, because the patient always needs his goal to be able to think, to work, and to help in developing this. So a patient is not only a disease, a patient is not only a deficit, but he very often has many problems. We have to tingle, like here we have to work with the motor deficit, we have to work with the motor and sensory deficits, and we have to work with the motor, sensory, and probably visual deficits. So we have to take everything into account and help to improve. And you see the different curves, how rapidly, if you consider only one strategy, if you consider only two strategies, or if you consider three strategies. So you really have to think about what you are looking at for the patient. What is very important for us neurosurgeons, and also for general surgeons, neurorehabilitation starts immediately after the injury, immediately after surgery. We have to start in the neurosurgical ICU. When neurosurgery sends patients to the neurorehabilitation unit, it's a combined work. So we would like to have these neurorehabilitation units as close to the neurosurgical wards, to the neurosurgical hospital as possible. And then we see the patient again when the complications occur. We in Northern Germany, or in Germany, we have a sort of sad situation that the patients are transferred somewhere else, 50 kilometers, 80 kilometers for rehabilitation. And then we get this patient tourism. When they come back, it's better, like I've seen in Hong Kong or other places, when the patient stays in the close to the unit. So we have a good cooperation from one to the other. And the patient care in the ICU, everything as you know. And then basal stimulation is important, and we have to have the patients as close to the relatives, as close to the patient as well. This is kind of basal stimulation. If a patient is lying flat, it starts opening his eyes. He should not only see the white roof, but he should have some visual impression, get some more information what's happening, like these pictures, simple pictures, and photos of the relatives and all these things, which are very important for them. Basal stimulation also by the nurses taking care of the patient and to motivate him to understand how it feels to be touched on the arm, and so on and so on. And also here, this kind of movement of the hand, of the wrists, and all these are basal stimulation techniques. And he's allowed to listen to music, hear the music he likes most, to get excited about, and so on. That's basal stimulation. Or like have some scent and and some feeling like feeling at home. So the patient needs to be graded. I mentioned this time stepwise process, and we have this early process, and we have the Bartle index of daily living, and 100% of this, all these details show what is possible, and all the items, and 100% means complete independence, control of bladder, control of stool, everything. And this needs to be taken every 2 weeks or so when it's patients. So patients improve already in the neuro early rehabilitation concerning visual problems, hearing disturbance, dysarthria, and all this. And you see this figure, this diagram, how they improve from admission to this discharge. And so dysphagia has dramatically improved. Visual problems have not so much improved, but so you can see many things. We grade the patient from the acute phase to the phase E. So it's an itemized process, and everything that lasts 4 weeks, 8 weeks, 8 weeks. So the patient or the relatives know that the patient is transferred from one unit to the other according to his needs, according to the stepwise procedures, as well supervised by the insurance companies in Germany, who play an important role getting patients back on a track. And it's very important. Sometimes patients are not be able to be rehabilitated completely, so they go to a nursing home and they have to be there. They can go from either phase, but mostly of those go back to normal life if possible. That's a dedicated team of many specialists, not only a nice surrounding, but you see many people here. There are some doctors as well who are standing very behind, but physiotherapist, speech therapist, logos, and everything. So it's very important to have them all moving and getting all these rehabilitation issues, like putting things together here, as you see here, in such a nice environment, and speech therapists and working on the speech and everything, working on difficult movements. And so they have to work very intensively, and then they get further duties to perform. They have to understand what's happening, and then to be able to go back to a normal life, everything in a nice setup. And then we have this phase B neurorehabilitation, like 6 years follow-up in nearly 1,300 patients that have been published, found out high age, as we all know, has a high risk of dying. And this is certainly more true even now in these days of COVID, when neurorehabilitation is more difficult with COVID patients. Not to negate this, that's it certainly adds some additional problems to the patient, to the relatives who cannot visit so frequently, and so on and so on. There are some limitations in the setting to have not to spread the infection further on. High points on GCS means a reduced risk of dying within 5 years. There are statistics from neurosurgical units as well, and swallowing impairment. They need surveillance and communication disorders. All this leads to reduced health-related quality of life. We know this from intuition, but it has also been proven by follow-up of these patients. Predictors of employment outcomes at 1 year: pre-injury employment status, level of education. An educated brain is much more able to cope with a problem than a not so well educated, not so well intermingled brain. So we have to understand, to help people to go back to their level, the best possible level, but we can never expect someone really to go back to 100% performance if we had a bad injury. Causes of spinal cord injury, work has been reduced from 1975 to 2011. As work injuries have dramatically been reduced, taking care of the patient, taking care of the work environment. Traffic has also dramatically reduced. Diving, which is very popular in our area close to the seaside, has stayed about the same. It's awful to see these diving injuries, young people diving and shallow water and getting tetraplegic immediately after they dive into. Other trauma like family injuries have increased, household injuries have dramatically increased. Okay, so that's kind of this neurorehabilitation unit, paraplegia, Hamburg-Bergedorf. You see, if all these people would need to wear masks, and the COVID correct setup would be certainly much, much more difficult to take care of all of them and to do it in a timely fashion. So there certainly would be much, much more problems. And then we have this locomotor rehabilitation, like they are they're walking in this, I don't know why this doesn't work today, there's some bug in there. Okay, on this young man who had been who is tetraplegic and not really breathing, he is on breathing, he is tracheostomized, he has a ventilator, and he's well taken care of by his mother and other people. He's young, 17, 18 years old. So what is going to be his future? That's an ethical issue. Should we always try to do everything which we can do for those people? He had been playing with his school classmates, and they had been twisting around. So he had got this wrestling injury, and he remained there. And how long can we take care of him and make a good environment for him? So I would like to hear many of your comments from the low and middle income countries. So that's the paraplegia center again. That's someone who came from Africa as a baseball player, and now he's a physiotherapist in this paraplegia center. And he understands the needs, and he understands that he had a car traffic accident, so he got also paraplegic. And he is now a physiotherapist and teaches paraplegia patients to improve and to depend on make an independent living as much as possible. So it's very important to understand the situation in which the patients are. That's when I visited Peshawar, it's the ICRAN 2019, supports the patient. They do everything on their own. They have an excellent job. They are well supported also by funds, and so it works quite well. But it's very important, it's not our disabilities that count, it's our abilities that count. We have to improve on the patient, on his moral feeling that he is able to do many, many things. He does painting, he does everything, and they have done an excellent job. We have seen ladies in this place who should be somewhere down in rural areas, but they are really very active in working, in making embroideries and everything. So they get really to excellent living conditions to live on their own because they have abilities that can be developed. That's very, very important. And that's very important. We have to have interaction between caregivers and patients. The GRIP, gain contact, register response, intention, interaction, partial participation, improve the goal setting, which is very, very important to always to remember of this, and to take care also of the relatives of the patients, to take care of their anxiety and depression. That's very important. Also, they like if our patient is the one who takes care of bringing the money or bringing the food to the family, obviously they get completely depressed. They lose the idea of how they can survive, and we have to take care of all these problems and help them as much as we can. Independence of patient, self-esteem, participation of social life, efficiency. I talked a little bit about this. Cost effectiveness, every country has to do its own. We have to do as much as possible, and we have to see that we can improve on these things. We have cultural differences. That's very important to remind. Comparing, there was a study a couple of years ago, comparing health-related quality of life of Dutch and Chinese patients with traumatic brain injuries. Very important to remind, there are the differences. And you see that the short form 36 profile of Dutch and Chinese patients, with scale score range from, and we have the bodily pain, general health, vitality, social functioning. There are differences in like general health is different. Chinese feel worse. Dutch people say, okay, I'm doing fine. So we have to consider these also different settings. Then we have to know what kind of intervention do we do so to those patients. They can be minimal invasive, like prospective memory rehabilitation using smartphones in patients with traumatic brain injury. They postulated that smartphone users have fewer memory problems, but this is only insignificant improvement. We can do something with the smartphones with some apps and so, but no real changes of quality of life, minimal invasive. We have the other Other possibilities, say Chinese people from the traditional Chinese Chinese medicine hospital, they wanted to study effect of auricular electroacupuncture combined with body acupuncture, improving consciousness of patient. They published a study protocol. They are very good in doing these study protocols for randomized study. I never saw any results from these studies. So I'm not quite sure whether it really helps, and we have to be very much aware of these slightly invasive possibilities. When we do research, we always have to remind that the bench is closer to the bedside than we think. We have to uncover the ethical ties between preclinical researchers and translational neuroscience and patients and clinics, and we can only launch new clinical trials ethically when new approaches show sufficient scientific promise. That's clear. But what if those studies, the initial studies, do not show do not use basic design elements as blinding as randomization? And I'm very, very skeptical about many studies which come out which really do not show so well that they use a scientific basis of all this research. It's very important. And your approaches need to show sufficient scientific promise. We need regulatory agencies to really supervise this, and I'm still the chairman of our research ethics committee at our university, and we have to be very, very strict that the risks need to be minimized and benefit dramatically outweighs the risk. So only then we are able to do all these studies. But it's important to these studies also in rehabilitation. We have technological advances which are in the news, which are in the lay news very much. Robotic surgery, brain-machine interface becoming more and more important, like making people hear again, making people see again, so that they're able to drive their cars, hopefully at the end. We have to know non-invasive alternatives. We have to be very much in the forefront of this this area. We have to understand everything about like virtual reality training. That's very fancy to do these in the computer or on the app, on the iPhone app or whatever. But we have to understand how much it really works. So a nice study from Peru, very simple, very poor country. They looked at the literature 2 years ago and they found that only 1/3 of all these devices which are commercially available for post-stroke rehabilitation offered through internet, only 1/3 had a randomized controlled trial that had proven efficacy for the rehabilitation purpose. So we have to be very skeptical about all these issues, about all these things which are sold through the internet, and which the patients want to get and relatives want to get. We have to treat them and we have to help them. So severity of the traumatic brain injury and the invasiveness of therapy, we have the basis always is physiotherapy, ergotherapy, basal stimulation. Then we have this external methods like regional transcranial magnetic stimulation. This can be improved further, and there are good data on this, and there are good research data also. And very, very at the very end, only for severe traumatic brain injuries come the invasive brain-machine interfaces like deep brain stimulation and other possibilities, which I don't want to talk about this. We have to improve future of our patients' bioresearch, human patient caregiver interaction, teleneurobitation, certainly also a very important field, training of machines, robots for repetitive tasks, but everything needs to be researched, assistive strategies as well, computer control. There are many, many things because we have a limitation of number of physiotherapists, but we cannot let the computer work on their own. The patient always needs to be supervised how he's doing brain machine to train activity dependent CNS plasticity at the very early stage, but we always have to do a good job taking care of these patients, we as doctors. Neuroprosthesis from Mark Tonano is certainly coming up in the next years. We have to be very much aware. We also have to be very much aware that we as neurosurgeons are involved in this business, also involved in this development of these techniques, but we have to protect our patients because much of this nanotechnology nowadays is paid by the military people, and we have to be aware that they do not take over what the progress, but we have to supervise what we really want to do. Ethics of neurorehabilitation, we have to restore the autonomy of the patient for himself or herself, and second to this, also to the society. So I apologize for my technical problems at the beginning, and I'm open for questions. Thank you.
Thank you, Professor, for quite an exhaustive talk on neurorehabilitation. Of course, you have talked about the ethical issues and the financial constraints which many face. I want to know your opinion in case of spinal cord, cervical spinal cord injury, maybe C4 and above, when there is a fracture dislocation and cord is almost transacted with lot of contusions upwards and downwards. Patient is quadriplegic, ventilator dependent. In such situations, what is your approach in Germany?
Well, you see, I've shown this young man who was 18, 17 or 18 years old, who was tetraplegic on the ventilator, who survived. And when we talk to him and when we look at him, he looked quite happy. So they did a great job in the initial hospital, in the rehabilitation unit. He had been in Hamburg and everything went fine for him. But I take this example always when I give talks on ethical issues in modern medicine. How far should we go with physiotherapy, with the antibiotics when he gets a pneumonia and so on and so on? People usually would say he should go on forever. We should go on forever, give him antibiotics. So if the antibiotics are exhausted, that's the long-term issue. We also have the acute situation. You're probably more asking for the acute situation. We also had a colleague of mine whom I very much liked. And he was in a nursing home because he had got demented after retirement. So he was in a nursing home, fell down in his wheelchair, fell down a couple of stairs, broke his C1 tooth. He got confused. He was intubated, brought to our emergency department, and trauma surgeons wanted to make a dental fusion, dental screw in there. So his wife told me, what is the benefit to him? So we decided we let him wake up over the night and without any medication and see what kind of neurological status he had. So just twisting his, making pain sensation. The only thing was he moved a little bit his eyes, wrinkled his eyes. So we decided all together with the family that we would stop therapy, took off the respirator, and he died immediately. So these are the two extremes. If you see some possibility in the setting to do something for this patient, it's certainly in our society, it would be kind of unethical not to do all what we can do. At a certain step, one has to think, is it really possible to do everything what you can do? I discussed with Indian colleagues as well. When I visited India, also rural areas, and say, well, we have a family patient, the father has an epidural hematoma. He can have spinal cord injury or epidural, whatever. And if we treat him to the very end and send him back home in a not 100% working condition, one daughter has to take care of him at daytime, the second daughter has to take care of him nighttime, the mother takes care of him in the morning. So 3 people take care of him, and the social function, social possibilities for the family go down to -0. So it's better for the patient to die for him, because he can never become anything helpful for the family, and the family would get ruined in such a situation. So it's a very difficult situation. We have talked at the moment. We have also shift in philosophy or ethical considerations in Germany, how far we should really go, because we also realize that we are going to the limitations of our possibilities at some point. We have the patient-centered approach, but even then we have to tell the patient, well, we cannot do very much for him, and you will never really be able to go to something. So we have more restrictions nowadays, but it's difficult to convey this opinion to the relatives.
Yes.
And,
Yeah.
one to ask, we know in children, the hypoxia, abuse, and hypotension are real more common causes of brain hypoxia and secondary damage. So, and all the children, they are not little adults. So, do you have any protocol for children rehabilitation different than adult, or same, or you have different team, and what are the problems you face in children?
Well, we have special children rehabilitation units. Special units where we send the children, and they have their own protocols. We know that they really do even more. They are much more attracted to the children because they have such a long way to go, and they do everything what they can do, and it's excellent. The work they are doing there. But I am not so. I could not tell you the difference between these and these, but they have their very special. We have specialized pediatric rehabilitation units.
Okay. Do you have any additional work or social worker work system for rehabilitation programs?
What do you mean work program?
This social worker for rehabilitation. We have a few area where we social worker, we teach them, they
Sure.
do rehabilitate.
When the patient is in the hospital in the neurorehabilitation unit, he and his family are visited by social workers, and like when they have a house, they have to know how they should whether they should need some modification in the household, whether they would need to transfer the bed somewhere. So that's taken care of very, very early on. Like wheelchair compatible entrance to the house and steps and all these things. That started very early on. That's also taken care by the insurance companies.
And in your opinion, you told about in your presentation about the music therapy. So do you give routinely to all the patient, or there are certain indication when you give?
So as early as possible, because you certainly have a similar experience when the nurses, they say, oh, we doctors, we see the patients 10 minutes, 15 minutes a day, for example, twice 7 or 10 minutes maybe. And the nurses stay much closer to the patient, but the relatives even are more attracted to the patient. So they realize when they touch the patient, they have some variations of breathing, of heartbeat, heart rate, and all these things. So they're much more in the brain of the patient going on than what we realize. So we encourage the relatives to come as often as possible to the ICU, and to stay, if possible, as long as possible with the patient, and to do the spatial stimulation, to bring in the music, what they like to hear, to bring in pictures. So if they open little glimpse of the eyes that see the children and so on, that's very important, this kind of stimulation. I definitely think so.
Thank you, Professor Ruth. Thank you, Professor Sinha, for the questions. With this, we move on to the third speaker of the webinar. May I welcome Professor Achal Sharma from Jaipur, India. Professor Achal Sharma is now the unit head in SMS Medical College, Department of Neurosurgery, and he has been professor for the past 9 years. He has taken training in keyhole surgery and minimally invasive endoscopic neurosurgery from University of Stuttgart, Germany. He also has received training in the management of head injury and hemostasis from Barrows Institute, Phoenix, Arizona, USA. He has more than 35 research publications, both nationally and internationally. And his area of special interest also includes the psychiatric disability in head injuries. So today he would be talking about psychiatry disability after head injuries and its rehabilitation. So Professor Achal Sharma, if you could start your presentation. You need to unmute yourself.
Now, can you hear me?
Yes, we can hear you.
So, can you see my screen?
No, we cannot see the screen. Yes, we can see the screen.
Yeah. Okay. So it is 4:45 in my city. Good evening, everybody. And first of all, I would like to give my sincere thanks to chairperson and the co-chairman for inviting me and giving me chance to speak up on a topic which is slight away from a normal management part of the head injury patients, because it is away from a neuro operation theater and neurosurgical ICUs. And the role of neuropsychic rehabilitation starts just after the recovery of the patients from his consciousness up to the when he goes to his home and then settle in the society. So understanding the traumatic brain injury from the psychological perspectives with the neurorehabilitations, with the special reference to the depression, anxiety, and the quality of. Before going to the story, is a video which shows the importance of this topic. The patient who had suffered from the head injury with the left side frontal contusion and subdural hematoma was unconscious, became conscious after the surgery, and we were happy. We discharged the patient, and the patient went come to my clinic after 6 months. It is in Hindi. I will translate it in the English for myself. When I asked the mode of injury, he said that the patient suffered after the road traffic accident, and he said that the patient is now not having interest in inside, and a loss of memory, difficulty in his sleep, and always thinking about, and try to go away from the house. When I asked about the patient, he was confident. He was saying that he's all right. But the end result, when I asked about the whether the patient attendants are happy, they said big no with my treatment. So with this, we start our story. It is the psychiatric disabilities in traumatic brain injury. We know that commonly we see the patient after the recovery suffer from the major depressive disorders, generalized anxiety disorders, or post-traumatic stress disorder. Whether they may be there may be a substance abuse or the drug abuse, personality changes and post-concussion syndrome. Many patients appear with the aggression in their behavior, fatigue, insomnia, and all of this affects the quality of life of the patient. So the most important various disabilities is the depression of the TBI. We know that depression will have the disease burden which is distincting to become, and it is become the second cause of the global disease burden. And despite disorder, it leads to significant dysfunctions, disability, poor quality of life in the sufferer, as well as significant burden to the caregivers. As WHO projection report, the major depression comes in amongst the top in the disability adjusted life years after the disease. And as we know that the various neurotransmitters which are there to regulate about the mood of the patient, in which the common are the norepinephrine, serotonin, and the dopamine. To construct the diagnosis of major depressive disorders, either one of the major depressive symptoms means the depressed mood, or apathy or loss of interest is required, and there may be 4 or more of other symptoms like the change in weight in the last 1 month period, or there is sleep disturbances, hypersomnia or insomnia, change in psychomotor agitations, feeling of fatigue, in which the important is pathological fatigue, not a routine fatigue. Feeling of guilt, there may be executive dysfunctions and suicidal ideation or thinking about the death. So 4 of these is required to construct the diagnosis of major depressive disorder. Depression is the most frequently reported psychiatric manifestation among survivor or TBI. It lowers the life satisfaction amongst the survivor of the TBI as well as to the family member. It's not only prolonged rehabilitations, but also increases the distress of the family and the patient. There are various factors which are responsible for the depression, the traumatic brain injury, the pre-existing depression. If it was there may be pre-injury personality type changes, site of anatomical damage into the brain, various neurochemical imbalances, integration of injury, and the lack of familial support. These are the causes for post-traumatic depression. Its symptoms of depression may be vary amongst individuals. May be the symptoms may not be recognized as part of depression because always it is diagnosed suppression. Sometimes depression may be comorbid with the anxiety and may present with the mixed depression and anxiety disorders. Following brain injury, active screening is essential for the recognition, its treatment, and prevention of recurrent depression after the discharge from the hospital. According to AHRQ evidence report, they reviewed about 115 clinical studies, conducted, synthesized the evidence, what is known and not known in these clinical issues, the research questions and the results of the report subject to expert input, peer review, and public comments. And according to them, the patients with the history of TBI are at the increased risk of the depression. Increased prevalence of depression is observed in multiple times point after the injury, ranging from just after the injury to the later period. Because the risk of depression after TBI is high over the extended period, its continuing screening is required. The severity of traumatic brain is not been established as an accurate predictor of the depression. So suggests the need for vigilance across all the severities of the TBI, either mild, moderate, or severe head injury, until the more evidence is available. While evidences exist for the treatment of normal people or in general population, there are studies lacking individual who has suffered depression after the traumatic brain injury. Various treatment options available for the in which the psychotropic medication like SSRI or NERIs, tricyclic antidepressants, monoamine oxidase inhibitors, and others non-FDA approved medications. And apart from that, psychotherapy, neuropsychological rehabilitation, community-based rehabilitation, complementary and alternative medicines, and neuromodulation therapies are there to treat the depression in general public. Another important disease after the head injury is the generalized anxiety disorders. The severity of cognitive changes depends on the degree of diffuse external injury, its volume and location of focal injuries. Incidence range from the 24 to 27% after traumatic brain injury. As compared to the general populations, people with brain injury twice the risk of generalized anxiety disorders, in which cerebral contusion is the most commonly implicated lesions, which involves multiple lobes, particularly left frontal and right temporal lobes, right orbitofrontal septohippocampi, and other part of the limbic system. Generalized anxiety disorder patients have a poor quality of life in traumatic brain injury. When we get the patient of frontal lobe injury, they suffer the frontal lobe dysfunction, in which either patient may present the pseudo-depressed state, in which this consists of behavioral slowness, outward displays of apathy, reduced sexual interest, loss of initiative, blunted effects. While opposite to this, patient also may present with a pseudo-psychopathic personality, in which there is poor impulse control, in which hyperkinesia, inappropriate sexual behavior, and general impairment of social skills. So we have to understand what the patient is suffering from. When we see the site of lesion with the psychiatric disorders, investigation shows that lesion laterality and regulation of emotional response has documented in increased anxiety and depression in patients with the right-sided lesion, while some researchers said that the increased anger and hostility were found in the left side lesion, particularly dorsolateral prefrontal cortex. Now come to the neuropsychiatric rehabilitation part, and this, as my previous speakers said, that the interdisciplinary team approach is the most important, because interdisciplinary intervention studies is required to manage patients with the brain disorders, in which the psychologist has the important specific role. In behavioral approaches, there are growing literature seeks the development of interface between the neuropsychology and behavioral therapy. And there has been successful application of behavioral interventions in 6 categories, like inappropriate social behavior, attention and motivation of the patient, unawareness of his deficit, when there is loss of memory, difficulty in language and speech, and when there is motor disturbances. Another very important part of the neuro rehabilitation is the rehabilitation to the family apart from the patient, because it is always lacking. It just a cognitive and behavioral impairment of the TBI patients who affects the family members functioning, as well as family members has a reciprocal effect on the patient's continuing rehabilitation outcomes. So the sequelae that most affected family functions may have presence of cognitive deficit of the patient, disorders of communications, the patient's emotional regression, frontal lobe behavior, his withdrawal contact, inappropriate social behavior, if the patient is suffering from depression, inability to resume within the family. Thus, the successful treatment of patients must involve appropriate family-based intervention, and that is very important, because always when we treat the patient and leave the family, it's difficult to manage the patient. Healthcare providers can implement 3 levels of intervention with the family. First, with their education. Second, the counseling and regular support. And third, the formalized therapy. In the education part, family members have to tell about the nature of injury, relevant behavioral part, and strategies in patient care throughout the entire rehabilitation process. In education is the frontline strategy to orient family to policies and procedure of the rehabilitation center. Another second is the counseling and the support. Family counseling promotes adaptive stressful integration of care patients system. Even the most intelligent and resources families will feel overwhelmed after a time. So support from the psychologist person, like the psychologists, social workers, treating doctors, counselors, they assist in the adjustment process. Primary interventions that is often useful in the acute settings involve helping family members, especially the spouse, to shift focus from the TBI patients to themselves also, because it's a long-term planning and the management. And the third level of intervention to the family is the formalized family therapy, because this form of intervention is the most time-consuming. Family therapy is most effective after acute inpatient rehabilitation, when family members fully realize what residual deficits remains and family systems feel stress in the absence of multiple supportive rehabilitation personnel. In the summary, family therapy is necessary and useful intervention that offers reaches peak effectiveness once rehabilitation gains have slowed down and TBI patients have returned home, and when there is no surrounding treating doctors or psychologists there. So it is important in that sense. Some specific targeted studies has been done in our center for the depression, quality of life, anxiety disorders, sleep or insomnia, and fatigue after the traumatic brain injury. These are the published articles regarding this topic. In the result, we can see the quality of life in post-TBI sample is low in all four its domain, means physical, psychological, social, and environment, according to WHO quality of life BREF scale. When we see depression in TBI sample, we can see the 42.15% in our study population suffered from the depression, in which more were female. When we see the association of depression with the quality of life TBI sample, it was low in all four domains in the quality of life. So that's why it is important to deal with in the treatment protocol. Another is the anxiety. Anxiety was seen in 11.7% in our study. Association of anxiety with quality of life shows that again the quality of life is lower in all its domain after the traumatic brain injury when we compare the patients who do not have anxiety disorder. We have seen 40.2% of study population suffered from insomnia, in which most of the patients were seen in the moderate after the moderate traumatic brain injury. In insomnia category, the correlation of insomnia with the duration or time period after the injury shows that the more patients suffer from the initial part of the after the injury. As the time lapses, the insomnia becomes better, but in initial part, it gives untoward effects to the patient's recovery. Insomnia is also causes lower quality of life in post-TBI sample. We have also done some research with the management of depression with the quality of life in post-traumatic brain injury patients, in which the 80 patients were taken amongst the 250 patients who have suffered from the depression post-traumatically. Half of the patients were given sertraline 50 milligram daily. Another half served as a controlled group. And in results, we have seen there was significant improvement in the mood symptoms in the sertraline group than the control group. When we did study about the role of sertraline in quality of life after the traumatic brain injury, the patient who have suffered with the depression, again, the quality of life was improved in the sertraline group. So WHO quality of life status analysis at the start and end of the study shows that all the four domains of quality of life improved significantly in the sertraline group than the control group without the sertraline treatment. Now, after the treatment, there is another interview in which we have given the management of the drug management as well as the psychotherapeutic management to the patient. Patient who has suffered from the right side temporal lobe contusion with subdural hematoma, and as it says that he was always suspicious, not talking to the family members, had sleep disturbances. And when we ask about whether he is happy with the treatment, and he said that he is satisfied with the results of the patients, that now he is better than before. So in conclusion part, the management of post TBI should also focus on the treatment of associated mood symptoms or psychiatric disorders, which is likely to be associated with the poor quality of life with these patients. Certainly, it has found to be effective in the treatment of the depression with a significant improvement in the quality of life in traumatic brain injury patients. Additional research in the future required for the patient who suffered with the depression of the traumatic brain injury and needed to compare the effectiveness of diagnostic approaches and timing and tools for the screening. Additional research is also needed to determine the whether patient's factors such as the area of brain injury, severity of the injury, mechanism of injury, his age, and gender are predisposition for the depression in the patients with TBI. Future research also should be randomized, use approaches that are clinically feasible, employ a comparison to control group where appropriate, ensure comparability of treatment group, and there should be a long-term outcome and results of depression treatment in patient with traumatic brain injury. These are needed for further comparison of the safety and effectiveness of the treatment. Thank you very much.
Thank you. Thank you, Professor Sharma, for the nice presentation on the psychiatric disabilities. One question is, do you see any differences between the Western population and the Indian population, or for that matter, any developing nation, as far as the psychiatric disabilities are concerned post head injury?
Although it should be the same, whether it is Western or Indian, apart from this, that the Indian perspective, the most of the patients are of poor, basic problem to earn the their daily needs. So it is more burden to the family if the patient is a young person who earns for the family and he suffers from the head injury and becomes the psychiatric illness, suffer from psychiatric illness, then it is very problematic to the family member to take these patients for the long-term treatment. But we have done our most of the study in the India, so we did not compare with the Western. But when I have gone through the literature part, my results were comparable to the Western.
Do you also believe that the educational status of the patient determines to some extent the psychiatric disabilities?
Yeah, of course. As we seen in my previous slides, I have shown the predisposing factors of post-TBI depression, in which the pre-existing illness, if it was there, the education status of the patient was there, his family and psychological or any drug abuse or patient suffering from the any previously stress. So all these factors are responsible for the post-traumatic brain injury psychiatric illness.
Okay.
This post. Yes, please.
I have asked this question about this differences between Western and Asian countries because they had social differences, and so it's very difficult to compare. I would understand. Here, most people are living alone, or very often are living in strange situations, like they have no family, but you have a strong family background, supposedly. So that's one part of the question. The other is, do you have neuropsychologists in your department who take care, who analyze these patients to see how much depression or how much functional deficits they have? Because I always found out it's very, very difficult to really differentiate these two, and it interacts depression patient who understands that he cannot function so much, he gets depressed. Someone who is depressed doesn't function so well. So it's a spinning wheel. And do you differentiate? How well do you differentiate, you as a neurosurgeon, or do you have people like you have a psychiatrist seeing the patients also, or on a routine basis, or psychologists or neuropsychologists?
Of course, we do have the psychiatrist with us, And in all my study, there was associated psychiatrist was associated with me in this. And we always in our department, because in our hospital, this is a tertiary based super specialty hospital, we have facility for the psychiatric colleagues and psychologists along with us.
Excellent. Thank you very
This
much.
neuropsychiatric behavior continues to be a matter of major public health concern. And for drug therapy, you choose sertraline. And there's so many other drugs available for that. So why you select sertraline?
Because as we discussed in earlier part of the presentation, there was, I told that there was three main neurochemical who were responsible for the mood disorders, in which one is the sertraline, which was most important, another norepinephrine, and the dopamine. So most of the depression was associated with the serotonin neuro. So this is certainly, this is SSRI, serotonin reuptake inhibitor. So we took the sertraline for this reason. Another, it has the lesser side effects, and its third is available free of cost in our center, and less side effects, of course, because in case of the insomnia and other things, when we use the amitriptyline, and that, it is, we have to look for the bleeding disorders or other problems if it is there when there is a contraindication.
Thank you. Professor Ruth, do you have any questions for Professor Sharma?
I've been very privileged to always have access to a neuropsychiatrist and neuropsychologists, better probably in the last 20 years than the previous 15, but it is so hard, I think, to work out whether somebody is depressed or affected cognitively due to a concomitant brain injury with spinal cord injury. And I'm really grateful that I've got people around who can help. But what do we do when we don't have a neuropsychologist to try and work out whether somebody is depressed or brain injured or both? And as we've already heard, the combination is often quite is well recognized that people can have both, but it's very difficult in those areas where people are working without those facilities and the people around to help. So what tests do you recommend to help people work out whether we're dealing with depression or brain injury?
Yeah, there are many tests are available, which was given by the WHO for the depression. There is test was given according to the patient health questionnaire was there. We use PHQ-9 standard of the Diagnostic and Statistical Manual of Mental Disorders, the book published from the American Psychiatric Association, and in which the 9 points were given to categorically we can ask, you give the simple, in the simple question form, we can ask the patient from them. And accordingly, we can divide the whether the patient is suffering from mild, moderate, and severe depression. When the patient get the score more than 10, then of course he is suffering from the this moderate or severe depression disorder. Likewise, for other psychiatric illnesses like insomnia, there is again insomnia severity index is there. For anxiety, again the scale is given by the WHO. these all are in questionnaire form. So we can diagnose the problem, and if the specialists are not available, we can refer the patient to the psychiatrist for the treatment of psychiatric part of the.
Yeah. I think that's helpful for the audience.
Thank you, Professor Achal Sharma.
Thank you.
We move on to the last speaker of today's webinar. May I welcome Matron Yi Yit Cheng. She is in the Department of Neurosurgery, Kuala Lumpur Hospital, Kuala Lumpur, Malaysia. She qualified as a state registered nurse in 1987 and had obtained the post-basic intensive care nursing in 1994 and post-basic midwifery in 1995. She received future advanced training in neurosurgical nursing in Fujita University, Japan in 2014, and has been attached to Department of Neurosurgery, Kuala Lumpur, Malaysia since 1991. She's a matron since 2009, and her special area of interest is neuro-intensive care nursing. She has also been organizing local and international nursing conferences since 2004, and she has visited various countries for her lectures. Today, she would be talking about neurorehabilitation in neurosurgical nurse perspective. Over to you, madam.
Thank you. Can you see my slide?
Yes.
Can you hear me?
Yes.
Can you see my slide?
Yes, we can see your slide.
Okay, thank you. Thank you for the opportunity given to me. This is my hospital. It's one of the biggest hospital in Southeast Asia. And my hospital is a big institution with 7 hospitals in one. And regarding neurorehabilitation, we mainly have our neurorehabilitation for our neurosurgical patients in the wards. So it is actually a complex medical process which to end recovery from a nervous system injury and to minimize or compensate for any functional alteration resulting from it. So first, neurorehabilitation works with the skill and attitude of the disabled person and his or her family and friends, promotes his or her skill to work at the highest level of independence possible for the patient. It encourages one to rebuild self-esteem and a possible positive mode, so can adapt to the new situation and become empowered for successful and committed community reintegration. So neurorehabilitation begins as soon as cerebral protection is completed in the neurointensive care unit with 2-hourly positioning to prevent pressure injury, chest physiotherapy, suctioning as required, and passive exercise. Those are all assisted by the nurses. Weaning off ventilator begins once patients have spontaneous breathing or GCS improving, as well as ABG acceptable, and there's no respiratory complication. It is, as everyone knows, it is a multidisciplinary approach that involves neurosurgeon, the rehab team, speech therapists, occupational therapists, physiotherapists, neuropsychologists, social worker, nurses, dietitian, and of course the family members. So this is a picture show rehabilitation starts in the neurointensive care itself as soon as possible and when conditions of patient permit. And this is a young boy after a traumatic brain injury and he sustained a subdural hematoma, operation done, patient extubated, and he recovered well with physiotherapies assisted by nurses and transferred out to the general ward. In neuro high dependency unit, we too ventilate patient as the neuro intensive care unit, and physiotherapies also will be assisted by the nurses over there, and patient recovered well and sent to the general ward. And rehabilitation to be continued in the general neurosurgical wards. And this is our bedding area for patients. And this is the only hospital that we have this area to bathe our patient every day without fail. And male surgical ward rehabilitation continue by the nurses and of course assisted by the physiotherapy. And due to the shortage of physiotherapists, and most of the rehabilitation is carried out by nurses in the ward. And of course, this is a photo, a picture showing cleanliness of patient done by a nurse, and bedding of patient. After bedding, patient will be set up on a rehab chair, and it is lifted by a hoist. And these are all done by nurses. And after that, in the morning, patients who are able to sit up will be on a rehab chair, and in front here there will be a television for them to entertain them and while they are having their breakfast. This is part of the rehabilitation in the ward, and most of the patients have their rehabilitation physiotherapies will be performed in the ward itself, because our gymnasium is only most of the time cater for outpatient. And so inpatient physiotherapy will be done in the ward. And this is a 35-year-old gentleman with hemorrhagic stroke. Patient came in unconscious, intubated, ventilated, and patient managed to be extubated and on a rehab program, all done in our ward, and patient recovered well and discharged. He was very obese, 147 kilograms, and by the time he discharged, he has gone down to 130 kilograms. And even with the limitation of equipment, we do rehabilitation with tilting table done by the physiotherapists and assisted by nurses in the ward. And the physiotherapists, with the help of the nurses, put patient on a tilting table, and we will monitor the patient so that the physiotherapist who is covering other wards can carry on his or her responsibility in other ward, and then he will come back to the ward concern. And what about younger patients? Younger patients, we stimulate them by giving them some drawings so that they will do some coloring, or by giving them some simple books to read, to stimulate them, and to some of them able to draw well, but some still not able to concentrate, but it takes time for us to really have to motivate this patient, and we nurses need to be very patient with them. And this is the female ward. And this patient suffer from hemangioblastoma, operated. She admitted with body weight of 140 kg, and she has gone down when she was discharged, and she came back for follow-up in the clinic. She has gone down 10 kilograms, and this is when she was already in the ward. And this is a young girl suffer from traumatic brain injury. She recovered well and discharged home. This is a lady with hypertensive bleed and physiotherapy assisted by nurses performed by the physiotherapists in the ward. This is a patient who unable to wean off from the ventilator in the intensive care, and she was then transferred to the ward, ventilated in the ward in slow weaning, and she did not come out, and she passed away. The role of a neurosurgical nurse is no different from a rehabilitation nurse, and she plays an active role in helping the patients to function at their best in meeting basic needs in the activities of daily living, provides coordination with the other members of the team, that is the dietitians, speech therapists, occupational therapists, and to provide effective patient and family education. And while preparing for patient before discharge, we have to come up with the training program for the carriers, identify who will be taking care of the patient, and we train the carriers on tracheostomy care and suctioning, personal hygiene, skin care, that include the bladder and the bowel care, NG feeding, physiotherapy with the help of physiotherapists, and we give them education on medication, and we do give a little bit of psychology support to the family. And preparation before patient discharge normally is discussed among the ward manager, the staff in charge of the patient with the doctors. Then the plan will be planned out, and we will refer to individual team. We have to, the neurosurgical team will have to refer to the rehab team. And then from the rehab team, they will then refer to the whoever required. So it is very complicated referral. So we prefer to do it in our own ward itself. And before after the discharge plan is up, then we will call for a family conference, identify who will be the carrier, and then where we, if required, we will refer them to the social welfare, the hospital level for financial support in order to get a bed or suction machine, repair mattress, wheelchair, ample time to learn up before discharge the patient. But there are limitations in our institution. where we have own very limited rehab chair, tilting table, and patient not able to send to the gym because it is only catered for outpatient and only can be done by the physiotherapist. And our institution only, we have a rehab ward, but only 10 beds. That is why they are very difficult for us and to send our patient over there for rehab. And because of heavy workload, nurses in the ward always occupied with heavy workload and only one physiotherapist, and sometimes the one physiotherapist need to in charge of few wards, occupational therapist, speech therapist, and we need to refer to them. That is why most of the responsibility, most of the rehab task is done by the nurses in the ward itself. Sometimes we do have family members who do not give cooperation, and sometimes because due to financial constraint that they are not able to be with the family, with the patient, to learn up how to take care of the patient. These are all our constraints. And during this COVID-19 pandemic, strictly no visitors, but nurses continue the neurorehabilitation in the ward, as our wards are non-COVID wards. And we train caregivers as usual, but we have to identify over the phone first before the caregiver come to the ward, and we only limit to one caregiver per session at one time. And we make sure all adhere to SOP, both the nurses and the caregivers. And if it's possible, video call, we let the patient video call with the family members to motivate them, so to encourage them and give them moral support. And how do we improve our nurses? We have our continuous nursing education. This is on a yearly basis. We involve the physiotherapists to give a session on how to leave patient, how to the proper way of exercise, passive exercise, range of motion exercise, and how to lead patient from the bed to the wheelchair, from the wheelchair to the bed, because our turnover of nurses is very fast, and these nurses are all very young nurses. And in conclusion, neurosurgical nurses play a vital role in the communication of patient status to family members and members of the healthcare team. The nursing assessment and plan of care needs to be fully integrated into the interdisciplinary plan of care to ensure holistic management and achievement of patient and family's goal. We don't promise any miracles, but we do believe they can happen. Thank you for your attention.
Thank you, Matron Cheng. The last slide was very realistic and interesting. We have a question for you that what we understand from your presentation is there is a dearth, there is a shortage of physiotherapists at your hospital. So, but there is an adequate number of nursing staff available. So is there any reason why there is more of nursing staff and less of physiotherapists? Is it a local cultural issue that people want to go for nursing as a career and not as a physiotherapist? Or is it because the pay scales are different?
Number one, the pay scale is different. And number two, because our hospital is a big institution, we have 86 clinical wards. So this physiotherapist needs to cover all the wards, which is the demand is more than the supply. Their intake is limited. That is why we nurses need to help out with physiotherapy for this patient.
And also, when you discharge the patients who are on tracheostomy tube, on needing a Ryle's tube feeding or maybe a PEG and physiotherapy, do you have some kind of a professional home care caregivers who actually go to their patient's home and provide all kinds of support, not just maybe the bed and physiotherapy, but even ventilator at times of need?
We do have these domiciliary services in our hospital. Before patient discharge, we will refer to the team, and the team will go and visit the patients once the patient discharged in the home. And from there, they will again guide the family members or the caregivers, and at the same time, they too give moral support. And if required, they will refer them to the hospital. If any complication, they refer them back to the hospital.
Okay. Thank you, Matron Cheng. Thank you.
Thank you.
I'm very happy to know that Cheng, you are looking after so much of neurorehabilitation care. Doing so good neurorehabilitation care in your ICU and your ward, and we see definitely very creditable. And with this, I think we had a good webinar. We had a good discussion after each lecture, and we must continue to meet again and again, because I think COVID problem is still going on. And I must thanks and special thanks to Professor Maximilian, Dr. Marshall, Dr. Achal Sharma, and Mr. Cheng for sparing time for this webinar. And I'm sure that with your share of your knowledge, it will help definitely our patients as well. And thank you, everyone. And with this, we conclude the webinar. Thank you.
Thank you. Thanks. Thank you. Bye-bye.
Invitation. Goodbye.
Bye.
Thank you.